Okay. Dr. Maurice Mosseri. I'm completing my endocrinology fellowship at South Brooklyn Health. Should be done in June. And next year, B'ezrat Hashem, I'll be joining practice on Route 35 in Oakhurst, called Atlantic Health for Endocrinology. I'm proud to be a member of this community. I've done a lot of volunteering with SBH, especially when I was in high school and in college. And I'm always happy to continue to give back throughout my career. Tonight, we are honored to be working with Dr. Sarah Barenbaum. She's an assistant professor of clinical medicine at Weill Cornell Medical College. She's the obesity medicine director, specifically working with GI, metabolic, and bariatric surgery. And she's also the program director of Obesity Medicine Fellowship. So, Dr. Barenbaum, what does your practice do?
Yeah, first of all, thank you so much for having me. I'm really happy to be here discussing some of these topics that are near and dear to my heart, and happy to share this information with everybody. My practice, so I am primarily at the Comprehensive Weight Control Center at Cornell. We are a large interdisciplinary practice. I'm an obesity medicine specialist, as you mentioned, but I also work with endocrinologists, bariatric surgeons, registered dietitians. We have a lot of NPs. We all work together because losing weight and maintaining weight loss is so hard that we try to provide really comprehensive care in all facets of weight loss.
Beautiful. Yeah, and it's something that I think many people are struggling with, and a lot of people have a lot of questions about our new GLP-1s. So I think everyone now has heard about drugs like Ozempic and Wegovy, our GLP-1 receptor agonists. So can you explain to us what is a GLP-1 and what does it do?
Sure, absolutely. So this is a great question, a great place for us to start. GLP-1 stands for glucagon-like peptide 1. It's a naturally occurring hormone that's primarily secreted in our gut when we eat. There are GLP-1 receptors that we have throughout our body, and when GLP-1 binds to these receptors, it helps to improve blood sugar control and promote weight loss through a variety of different mechanisms. So when GLP-1 binds to receptors in the gut, for example, it leads to a slowing of the emptying of the stomach and a subsequent reduction in food intake. It helps to reduce portion sizes, for example, and appetite. But GLP-1 also binds to receptors in the brain, which help to regulate appetite. It plays an important role in blood sugar control as well, through insulin pathways and stimulation of insulin. And therapeutically, the GLP-1 receptor agonists have been developed for the treatment of type 2 diabetes and obesity. So these medications bind to our GLP-1 receptors and help improve blood sugar control and promote weight loss by mimicking or enhancing the action of the GLP-1 hormone that we already make.
So GLP-1 is something that the body produces naturally then?
Yes, correct. It is secreted when we eat. It's naturally produced.
So we've also heard about, Mounjaro and Zepbound. What's the difference between Ozempic, Wegovy, and Mounjaro or Zepbound?
Yeah, so this can be really confusing. So I'm going to try and take my time and explain this. And I think one of the reasons it's so confusing is these are four names for only two drugs. So Ozempic and Wegovy are both GLP-1 receptor agonists, and they contain the same active ingredient, semaglutide. They have different brand names because they're FDA approved for different uses. Ozempic is approved for the treatment of diabetes, and Wegovy is approved for chronic weight management. But again, they're both the same medication. They're both semaglutide. Similarly, Mounjaro and Zepbound are both the same medication that contain the same active ingredient, tirzepatide. They have different brand names because they're FDA approved for different uses. Mounjaro is approved for the treatment of diabetes, and Zepbound is approved for chronic weight management. But again, they're the same medicine. They're both tirzepatide. So the main difference between semaglutide and tirzepatide, or Ozempic, Wegovy, and Mounjaro and Zepbound, is that while Ozempic and Wegovy is what we just introduced as a GLP-1 receptor agonist, Mounjaro and Zepbound are a GLP-1 and GIP dual agonist, meaning they're targeting two hormones instead of just one. They're targeting GLP-1 and GIP. So you're probably wondering, what is GIP? I've just introduced a new name. GIP stands for, it's a mouthful, glucose-dependent insulinotropic polypeptide. We call it GIP for short. It's another naturally occurring hormone secreted in our guts in response to nutrient intake when we eat. And there are also GIP receptors throughout the body. So along with GLP-1, GIP basically helps to support the work of GLP-1. So I hope I answered that question. We have really 2 medications, but 4 names for them.
But in terms of like our practical effects, right? So what's the practical difference as opposed to just the hormonal difference?
The practical difference, I mean, they're used relatively interchangeably, like clinically, if that's what you mean. Uh, in the trials and in clinical practice, Mounjaro and Zepbound, well, Zepbound is the one that's approved for weight loss, is a little bit more effective than Wegovy, but it doesn't really make Wegovy an ineffective or inferior medication. It's a great medication also. So, it really depends on the person and which might be a more practical medication to use. But I would say clinically, we think about them as very similar, and we decide based on insurance coverage and, individual issues.
Yeah, I think a good tidbit that I heard is now that Zepbound's being covered for obstructive sleep apnea.
Yes.
So it's a new, fresh indication for Zepbound.
Yes, that was really exciting. That indication came out a couple months ago and has provided more coverage for it. That's a great point.
So who should be taking these medications and who shouldn't?
Yeah, no. So I want to just start by saying that the foundations of weight management and of weight loss will always be diet and exercise. This is always going to be the cornerstone of everything we're focusing on. But lifestyle is not always successful to help people lose and maintain weight loss long term. And that's where the medications can help provide support to lifestyle changes to help lower calories and sustain weight loss. So we have guidelines that tells us who should and should not be taking the medications. The guidelines tell us that anybody with a BMI or body mass index greater or 27 or greater and a weight-related medical issue like high blood pressure, high cholesterol, type 2 diabetes, or anybody with a BMI 30 or greater who has not lost and maintained weight loss with lifestyle interventions for over 6 months is a candidate for these medications. That's kind of our baseline and how we think about these medicines. So people who should not take them are people who don't meet this criteria, people whose BMI is not high enough, for example, because they'd be concerned that the risks of the medication at that point outweigh the benefits of them, or anybody who has an absolute contraindication, um, which would include somebody who is pregnant or trying to get pregnant. These medications must be stopped 2 months before pregnancy. Anyone who's breastfeeding, they're excreted into breast milk. Anyone who's had a history of pancreatitis, these medications can cause pancreatitis and it hasn't been studied in people who've had pancreatitis. Anyone with a personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia type 2. And these medicines haven't been studied in people who have type 1 diabetes, but we do see it used off-label a lot for it.
Yeah, on the subject of the medullary thyroid cancer, I've
Yeah.
had several docs reach out to me and ask me, if it's okay to give Ozempic to a patient who's had previous papillary thyroid cancer and has already had the cancer surgically removed and radioactively treated. And the answer to that is, those patients are actually at a lower risk for medullary thyroid carcinoma, given that they don't have a thyroid. Right?
That's true. The risk, the warning for medullary thyroid carcinoma also comes from rat studies.
Yeah.
The rats had a higher risk of developing this very rare kind of cancer. They were given supratherapeutic, meaning higher than therapeutic doses, and they have more receptors for GLP-1 than humans do. It was not replicated in primate studies. It hasn't been seen clinically, but it's out of an abundance of caution that we don't prescribe it to anybody who's had a personal or family history of medullary thyroid carcinoma.
Right. And I think that, it's a kind of condition that if you've had it, if you have a family member who's had it, maybe it should be on your mind, but otherwise it isn't really something that you should be overly concerned about.
Agree. Totally agree. If anything, losing weight helps to reduce the risk of developing cancers. We know that excess weight is a risk factor for cancer.
So what kind of weight loss do you think, what's the average weight loss on these medications in the clinical trials? And what can patient expect to lose when they start these medications?
Yeah, absolutely. So this is one of the most common questions that I get from patients when I meet them for the first time, which is how much weight can I expect to lose on a medication? And this is a really hard question to answer because it can really vary, and it really depends on the individual and their own health journey, including what other medical conditions they have, what their history of weight loss has been, and weight regain, if they're on any other medications that might be causing weight gain, for example. Um, we use the clinical data to help our understanding of what the average weight loss is on a medication in the clinical trials, but it can really, really vary in clinical practice. With that said, in the Wegovy trials, they were 68 weeks long, and average weight loss in those trials was about 17% total body weight at 68 weeks. And about 35% of the participants in that study lost 20% or more of their body weight. The Zepbound studies were over 72 weeks. In that, it was about 22 to 23%, so I think it was 22.5% at 72 weeks, and nearly 40% of participants lost 25 or greater percent of their total body weight. So these are very, very impressive results in the clinical trials, but the clinical trials don't always play out in real life. There are also people in the trials in real life who don't respond to these medications. They're not magic bullets. 10 to 15% of people don't lose weight on these medications in the trials, and we see that clinically too. And then there's some people who lose 50% of their body weight, and then most other people fall somewhere in between.
When you talk about numbers like 50%, and I know there's like other GLP-1s and triple agonists in production, and do you think down the line, maybe 10 or 20 years from now, we could see medications that actually rival bariatric surgery, just given that you work very close with the bariatric surgery team?
Yeah, it's a great question. I would argue these medications already are rivaling bariatric surgery. I mean, with a sleeve gastrectomy, we expect about 25% total body weight loss. With a Roux-en-Y, maybe 30%. The medications are getting pretty close. When I say 50%, that's like really rare. That's what we call a super responder. It is not common for me to see that kind of weight loss, just to give you a sense of the range of things we can see. Um, I do think there's more medications in development that might be more potent, but I also kind of, to be honest, worry about those medications that are so strong, because at what point is it too much weight loss that we can create by medications? And at what point does that become concerning in tipping people into too much weight loss, which is also not a healthy thing? But I do think we are, to your point, we are going to see in the next couple of years, in the next 2 to 3 years, I think a couple of new agents coming to market, which are going to be really exciting. And we'll see, those clinical trials are ongoing, just uh, how effective, if they will be more or similarly effective. And either way, it's just great to have more options in case, somebody doesn't respond to these two. What else will be out there? Maybe they'll respond to those.
So, but in terms of what we have right now, what can a patient actually expect to feel when they start a GLP-1 in terms of appetite, food noise, and other feelings?
Sure. So clinically, people tend to lose weight because they start to feel fuller faster with the medication. They feel fuller for longer. It really helps to reduce portion sizes. This is based on that slowing of the stomach. Um, it also, as I mentioned before, it works on the appetite centers in the brain, and it can really turn down like food thinking, food thoughts, what's come to be coined as like food noise, and just kind of snacking and grazing and binging as kind of an added benefit from it. But everyone's different. Some people have all of these effects. Some people just have one or two. We just don't know until we try how somebody is going to feel. But this is like the common way they feel.
So, what are some common side effects that people can expect when they start a GLP-1?
So yeah, I warn people that side effects are common, but usually they're not so bad that somebody has to stop the medication. They're usually things we can work with, but the most common side effects tend to be stomach related. So like nausea, occasionally vomiting, diarrhea or constipation, more often constipation than diarrhea, acid reflux, and like abdominal pain are definitely, these are the most common ones. Um, there's a laundry list of potential side effects. As with any medication, like if you look at your Tylenol, there's going to be tons and tons of possible side effects. But these are the most common. And, especially with these GI side effects, it's really important if you start a medication and you're having these side effects to talk to the provider that's prescribing it, because we have so many strategies to help like reduce the side effects so that people can tolerate it, whether it's increasing the dose very slowly rather than increasing it once a month, which we can do. Or if you're on a higher dose and you start having side effects, we can decrease the dose, which can help people tolerate it better. So there's a lot of, and we can talk about like, are you having food triggers? Like some people might have a glass of wine or a really high fat meal the night before and then feel terrible the next day. So we look for food triggers too. So there's a lot of different ways we can mitigate these side effects to help people stay on the medications. And so it's important to not be overly concerned if you're having the side effects and talk to your provider. They might be able to help.
Yeah, I've had a few patients who just completely couldn't tolerate meat, red
Yeah.
meat, chicken at all while they were on the GLP-1.
Yeah.
But those are common. What about our more serious side effects? I know you mentioned the pancreatitis.
Yes. Pancreatitis is very, very rare, but it is our most feared clinical side effect because it's very, very, it can be very dangerous. People have severe stomach pain, they're throwing up, we have to send them to the hospital. So this is one that I always warn people about. Um, Again, it's rare, but it can happen to anybody. There can be gallbladder disease, like acute gallbladder disease. Gallstones can form, and if those gallstones form, they can block the gallbladder and they can block the pancreas. This is also rare. There's a warning for acute kidney injury, but this is really not because of the medication itself. It's because of diarrhea. Like if people have a lot of diarrhea and they're not staying hydrated, they can develop an acute kidney injury. Any
I,
severe like GI, like, oh, sorry, go ahead.
I think that kidney injury is particularly interesting because now I've seen data suggesting that it protects against kidney disease and progression. So
Yes,
it's really just about that volume loss from the diarrhea.
yeah, thank you for clarifying. It's definitely the volume loss. Ozempic has the FDA approval for reducing the progression of chronic kidney disease. So we know that generally people who have kidney disease, these medications can be really beneficial, but that there is that warning. And so some people who've had kidney disease really bring it to me and ask, like, I'm really worried about this warning on the medication. I tell them it's not from the medicine. It's from if you have like intractable diarrhea. Um, Hypoglycemia, so low blood sugar is a rare complication. It's really usually only when it's combined with insulin or other medications that cause low blood sugar. It's exceedingly rare that I see it in people who don't have other medications. Um, and for people who have, we worry about diabetic retinopathy complications too, and people who have diabetic retinopathy.
So what about, have you had patients, something that we're always worried about is in the elderly patients specifically losing muscle and
Yeah.
then worsening their chances of a fracture or osteoporosis. So how do you counsel patients specifically about muscle loss? Because again, when you're losing fat, you're also going to lose muscle.
Yeah, this is a really great point. With any weight loss, not because of the medications themselves, but with any weight loss, we see loss of muscle mass. And so we definitely talk about this up front too. These medications might exacerbate it a little bit, but it's still, there's a lot we don't know about what it means to lose the muscle mass. Um, there are some studies that suggest that the muscle that's left, the quality is actually superior to the muscle that was there before. But it's an area of active investigation for sure. We need to learn a lot more. We don't really know. But because we know people do lose muscle mass, we focus on the strength training up front. And we recommend, as part of our just general guidelines for weight loss, we recommend 150 minutes a week of exercise, mostly cardio. And we recommend strength training twice a week to help maintain that muscle mass. Eating a high protein diet can also help to maintain the muscle mass. It's not just the muscle I worry about, as you were just mentioning, bones too. I worry about weight loss from the bones can lead to weakening of bones. And so this is also why we talk about like impact aerobics to help maintain the bone strength. In elderly patients or people who are higher risk, I will be more cautious with weight loss. I may, we might do a DEXA scan, which is a way for us to do a body composition to look at these things and monitor over time. It's challenging because they're often not covered by insurance. But these are things that we can consider. And we, for elderly or more frail patients, I definitely have a conversation much sooner about let's be really careful and cautious with the weight loss. We don't want too much weight loss because that could put your health at risk too.
So what are some other reasons not to take the medications, contraindications to taking these medications?
Yeah, I think I actually mentioned this before. The pregnancy is an absolute contraindication. It must be discontinued 2 months before breastfeeding. Um, Pancreatitis, the family or personal history of multiple endocrine neoplasia or medullary thyroid carcinoma.
So just on the note on pancreatitis, even if for everybody out there who's listening, if you haven't had pancreatitis but you drink a really excessive amount of alcohol, uh, excessive alcohol combined with the GLP-1 is really a recipe for pancreatitis, and it's just something that you should be avoiding, right? Obviously, tell your doctor if you drink, and if you do drink a lot, you should not be taking a GLP-1. Um, so what about the newer drugs? What are the risks of the newer drugs on the market?
The the newer drugs, meaning the ones that are currently approved,
Yes.
like the ones that we're talking about. So the risks of these newer drugs, I would argue they're not that new. I mean, Ozempic was FDA approved in 2017 for diabetes, and we've been using it off label for weight loss ever since. And this family of medications has actually been around for much longer than that, under names nobody's ever heard of because we rarely use them anymore because they're not as effective. So we have actually a lot of data for a couple of like decades that these medications really seem to be safe to be on long term. And we know the FDA has been poking around for reasons that they might not be because there's so many people on them now. They really want to make sure that they're really safe. And so, from everything that we know, and thinking about the risks of excess weight versus the risks of these medications, we really think that the benefits outweigh the risks. So, you never know. Like, I can't predict the future. I don't know what we might learn in 5 years, 10 years, but we really believe these are safe long term medications.
What are some limitations that these medications have?
Yeah, so some limitations. They're not a magic bullet. Not everybody loses weight on them. Not everybody can tolerate them. Um, there can also be access issues. There have been shortages historically. There are no shortages now, which is great. But every once in a while, a medication will be unavailable for like 3 months or longer. Uh, a lot of insurances don't cover these medications. This is a huge access issue, and the out of pocket cost can be insane. They're very expensive out of pocket. Um, they might not lead to enough weight loss to improve health, right? Even though we're talking about 25% total body weight loss, for some, that's not enough to lead to resolution of weight related medical conditions. Even if it helps, it may not be enough. Or it can lead to too much weight loss, like when we're talking about elderly, frail patients, for example, and loss of lean mass and increased frailty.
Are there any other medications that you like to use for weight loss?
Yes, absolutely. These are not the only medications. And I think this is something that the media has like really found these medications in the last couple of years, these injectable medications. And um, no one ever really talks about our older medications, what we call our first generation medications. But there are definitely other options if you don't tolerate the injectable medications, or they don't work for you, or you're not interested in a weekly injection. These older medications can be really, really amazing. Um, the oh, go ahead.
So why do we prefer GLP-1s over these other medications?
Yeah, so I mean, if we're looking at clinical trial data, like the way that we have defined second generation versus first generation medications is the second generation medications lead to more than 10% weight loss, whereas the first generation medications lead to 10% or less. So we might favor, in somebody who doesn't need to lose as much weight, we might favor some of these older medications over the injectable medications. But it's really an individual discussion with each person about what their preference is, what their insurance will cover, what is safe for them. Can we use a medication to treat two different things? We would use an injectable medication if somebody has diabetes and excess weight, for example. Um, but if someone is, trying to quit smoking, we might use a medication called Contrave or bupropion naltrexone. So there's really a lot of thought that goes into what medication is right for the person.
Just because you mentioned smoking, did you see this study involving GLP-1s and how they reduce cravings for smoking and gambling and other dopamine releasing activities?
Yeah, it's really interesting. I think we're going to see a lot more studies coming out showing, I think, similar findings and similar pathways. I think it's a lot of these pathways are really interrelated in the brain.
Yeah, the gut and the brain seem to be working together.
Yeah.
Um, Can these medications be used to jumpstart weight loss and then reset a metabolism? And if not, how long should people plan on taking them for?
So this is something I always like to talk about up front too when we're talking about medications, because medications are meant to be long term. They are meant for chronic weight management. They change your physiology when you're taking them, but they don't change your physiology forever. And so that's why we think of them as lifelong. Excess weight or obesity is a chronic disease of abnormal energy regulation. And so when anybody loses weight, there are biological forces that limit weight loss and promote weight regain over time. There's an increase of the hunger hormone and a decrease of satiety hormones. This leads to altered food preferences, increased hunger, increased cravings, and also when anyone loses weight, there's a persistent reduction in metabolism. All of this is because when we lose weight, our bodies think that we are starving, and we have evolved to not starve. Our bodies are very smart and very efficient at holding on to energy. So I often tell people to think about a medication for weight loss the same way they might think about a medication for any other chronic condition, like high blood pressure, for example. If you start a medication for high blood pressure and your blood pressure becomes normal on the medication, you wouldn't stop the medication because blood pressure goes back up. But I always tell people I'm not going to force you to take a medicine forever. It's up to you. This is just what we know based on clinical trials and clinical experience that, you know, we really recommend these being long-term medications, but we can always work towards trying to come off of them if that is somebody's preference.
So, just in terms of coming off, I've heard that people do them every 9 or every 10 days as a
Mm-hmm.
sort of weaning protocol, but they don't actually come off of it. You're decreasing the amount of doses you take a month. The
Yeah,
idea being to reach some kind of a plateau period.
totally. So there's a lot of different strategies on how to like reduce or change the way we're dosing medications at a plateau. One might be we sometimes go as far as every 2 weeks, as long as somebody isn't having side effects. Like we might do a dose every 2 weeks if someone's at a goal weight and looking to reduce medication. Um, there are, we typically in our practice, we start low and go slow is kind of our mantra. So we'll start with the starting doses. And as long as someone's still losing weight, we will continue those doses past the 4 weeks where they often recommend increasing the dose because you're not going to lose weight faster if we keep increasing the dose, but you're more likely to have side effects. The added benefit to that is, aside from helping with tolerability, people eventually plateau on a given dose and they might plateau at their goal weight on a low dose, and then we don't need to make any changes.
So, what happens if someone just abruptly stops taking the medication?
Yeah, if someone stops the medication, there is a real risk of regaining weight. Most people regain weight when they stop the medication because, again, they're only treating that underlying biology while you're still on it. And we've seen this through clinical trial after clinical trial, and we see it in clinical practice too. It's really hard to maintain significant weight loss in the setting of all of those metabolic adaptations I was describing. But that's not to say it's impossible. Some people do come off successfully. I just warn people there's this risk. Um, but if it's, we can definitely try, but I do really think about them as long term.
Yeah, I think the study read said something like people gain 50% of the weight back within 2 years, and that's only 2 years after discontinuing the medication.
It
Something
can
along those
really
lines.
Yeah, it can really depend. I mean, if you look at the trials, step 4 and surmount 4 for Wegovy and Zepbound, over basically the way that these were the weight maintenance trials for the drug approvals, the phase 3 trials. And essentially, they have a lead in phase where everybody on the trial is on the medication. It's open label to begin with. And then they randomize them to either stay on the medication or switch to placebo. And the people who are switched to placebo regain weight like pretty significantly, whereas the people who maintain on the medication continue to lose weight. So again, not everybody. There's always individual variability, but that's what we really are thinking about.
So I know that for the diabetics, generally speaking, insurance does cover the medications, generally, not always. But what about just for weight loss? Are these medications covered? And is there a generic version?
So yes, this is a really, really challenging issue because some insurance companies cover weight loss medications and some don't. And sometimes the insurance companies move the target of what they will cover it for. Like this January, I saw them change So a lot of insurance companies moved the target for BMI criteria. So it's really hard to get these medications covered, or can be hard. But fortunately, there are some insurances that do cover them, and that's great. And as you mentioned, also sometimes we can get them covered for different indications, like Zepbound, for example, is now approved for obstructive sleep apnea. And so some insurance companies may not cover Zepbound for weight loss, but they'll cover it for sleep apnea. So we look for different reasons and different ways to get it covered. Um, there are programs now that exist through the companies that make these medications themselves that are out of pocket, that are reducing the cost. If you go to your local drugstore, these medications can easily be $1,000 a month. That's what I mean when I keep saying this is like insane. But there are direct to consumer, no, not direct to consumer. I can send a prescription now to either NovoCare, which is Novo Nordisk's program. They make Wegovy, or I can send it to Lilly Direct, which is Eli Lilly's program for Zepbound, and it's about half the price. It's about $500 ultimately a month, which is still very expensive, but the least expensive way for us to do this for patients. And that's why I always remind people we have other medicines. Nothing's a magic bullet. We can try other things if your insurance doesn't cover it. I think you asked about generic versions of them.
Yeah.
There are no generic versions of these medications. Sometimes people confuse this with compounded medications, which is a question I get asked about a lot. And I do think it's important to take a second to talk about like what compounded medications are, because so many people are on them. Compounded medications are not FDA approved medications. Compounding pharmacies source ingredients for these drugs from all over the world, because Eli Lilly and Novo Nordisk are not selling the ingredients to semaglutide or tirzepatide. And then the compounding pharmacies recreate the medications, but the medications they create are not reviewed by the FDA for safety, efficacy, or quality. So the FDA and a lot of professional organizations have spoken out against the compounded medications, and there have been reports of adverse events. So while some compounding pharmacies might be excellent, I don't recommend them because I don't know how to know if one is making the real deal or not. And there's no way for me to know what somebody is putting in their body. Compounding GLP-1s is also only legal while there's shortages, but there are no longer shortages of these medications. And so it's already illegal to compound tirzepatide and will be illegal to compound semaglutide sometime in May.
Yeah, I saw that they're going to be making it illegal now, the compounding.
Yeah.
So we have some questions to answer. Well, really one that I think is particularly interesting. Can tirzepatide cause excessive bleeding during surgery? And just we can discuss, surgical risks for patient taking these medications.
Yes. So I should say, yes, I'm happy to answer the question. No, there's no increased risk of bleeding. The medications are stopped 2 weeks before. It really can depend. Some hospitals require 1 week, some require 2 weeks. There aren't really guidelines because there isn't enough evidence for guidelines, but the guidance provided by the American Association of Anesthesiologists.
Anesthesia, yeah.
Yeah, they recommend 1 week off the medication. And different hospitals have different protocols before surgery. About whether or not you can eat the day before. A lot of anesthesiologists will require a prolonged, like at least 24-hour fast, if not a little bit longer, for people who are on the GLP-1 medications. And that is because they're worried about food being left over in your stomach, which can be a real risk if you have a procedure under anesthesia. They don't want people to aspirate.
The next question I'd like to address is metformin a good medication for weight loss? Can this come up on the screen? Is it coming up? Yes.
Yeah, so we use metformin off-label for weight loss all the time. It's one of our favorite medications. In that it is off-label though. It's FDA approved for diabetes. It's used off-label for pre-diabetes, PCOS, weight loss. It hasn't gone through the same rigorous trials because it's an old generic medication. It's made by like 38 different companies, and nobody wants to put the money into the trials to have it approved for weight loss. But like anecdotally, it really helps or it doesn't. Some people respond beautifully, some people don't. It's like any other medication.
And generally speaking, it's very well tolerated. And The opposite of the GLP-1s, it is very cheap.
Yes, yes, absolutely. It's like $5 a month. It's like universally covered. So it's a great medication to try.
Um, Here. So we discussed the compound versions. Um, can someone who has PCOS take these medications?
Definitely. I mean, it comes back to the original criteria also, like, do you have excess weight too? Um, but if it's specifically to treat PCOS and you have a normal weight, then we wouldn't prescribe one of like the GLP-1 medications. There's some like anecdotal evidence that it might help PCOS symptoms. Um, it doesn't have an FDA approval for PCOS, but like there's no contraindication.
So I've used it to treat not PCOS, but to treat obesity in patients with PCOS using
Yeah,
PCOS as a comorbidity.
yeah.
And we know the first line treatment for PCOS is ultimately weight loss. So if you're obese or not obese, if your BMI is greater than 27, so not
Hmm.
quite hitting that 30 threshold, the GLP-1s are a great option. Obviously, in addition to metformin, metformin is still one of the first line treatments for PCOS, metformin and the oral contraceptives. Um, okay. So if you'd like to discuss the compounding a little bit more, the compounding versions.
Yeah.
Like,
Go ahead.
are they as effective, and what's the catch? Yes, what's your biggest concern about compounding?
Yeah, I mean, my biggest concern is that I have absolutely no idea what you're putting in your body. I cannot say it's safe or not, right? So, because these are not FDA regulated and they're not FDA approved, we have no idea what they actually are. I don't know if the semaglutide a compounding pharmacy is selling is actually semaglutide. That's what I am the most concerned about. They haven't been studied for efficacy. They haven't been studied for safety. So I can't say how effective they are, if they are as effective or not. Also, because I don't know if it's the same medication. So it's hard, impossible to answer. I do recommend against them. And also, in a couple of weeks, they won't exist anymore. They shouldn't.
Yeah, they're essentially unregulated, and they can put whatever they want in it. You just have to trust them. So that has its significant drawbacks.
Totally.
So if someone's on these medications for over a year and has not lost weight, what would you recommend they do?
Yeah.
Let's assume
So,
that they maxed out the dose already.
yes. That's a good point because if somebody hasn't maxed out the dose, I would keep taking them up because there's sometimes we don't see people lose weight until they're on the maximum dose. I don't typically give it a year. By our guidelines, we look at least 3 months. Part of it also really depends on what else is going on, though, like our diet and exercise on track too, because while these medications can help that get on track for long-term success, they need to be on track. But if medication is just not working, if someone is not responding to it, we change the medication. We have lots of other medications. And just because somebody doesn't respond to one medication does not mean they won't respond to another. And that's where our oral pills that I was mentioning before, like the other options, can be a great thing to try.
So and then the basis of this question assumes appropriate compliance, but just anecdotally, I've had patients who thought they were injecting and they were not. They
Hmm.
didn't take the cap off, they didn't push the needle all the way. So what I like to do with my patients is I have them come in the first time that they use the medication, and at least the very first time I make sure they do it the right way, and I teach them. Because a little education can go a long way.
That's true. That's definitely true.
So if it's safe, why do we need to stop at 2 months before becoming pregnant?
Well, it's safe for us long term, right? But we don't have any data for what happens to a fetus. We know that these medications cross the placenta, and we don't know whether or not there's fetal harm in these medications. It's unethical to study medications in pregnant people. So, out of an abundance of caution, we stop them 2 months before. We'll get more and more data as people accidentally get pregnant on these medications. But I always tell people you don't want to be the data point. So we always stop them 2 months before. I think something that is really important to mention while we're talking about this right now also is something I think a lot of prescribers forget to mention sometimes, which is that if you're on Zepbound or Mounjaro and you're taking a birth control pill, when you start the medication or increase the dose, that birth control pill is not effective for those 4 weeks. At week 5, it's effective again. This is because it's altering how we absorb things from our stomach because it's slowing down our stomach emptying. So it's really important to use a backup method of contraception when you're starting or increasing the dose of Mounjaro or Zepbound.
And I think the other point, back to what you said in terms of medications and pregnancy, it's very rare to find medications that are approved safe for pregnancy
Yeah.
just because of the hesitancy in terms of treating. Like if you remember from our discussion before, metformin is probably our oldest diabetic oral
Yeah.
medication, and that only recently became approved for use during pregnancy.
Yeah.
It really does take a really long time.
Totally. And I think another important thing is that you have to gain weight during pregnant, right? It wouldn't be healthy if you're not gaining weight during a pregnancy because you're on one of the medications. So it's another thing to think about.
Yeah. Um, So aside from the addiction aspect, are there any other positive side effects, side benefits, let's call it, of these medications besides for what we mentioned?
Side benefits. Um, I've had so many people come and say, this medication has been really life-changing. I didn't realize how much thinking about food was really impacting me every day and how much I was just thinking about what I'm eating now, what I'm eating later. This food noise can be really pervasive. And I think one of the most important, good side effects is that really turns it off for people. Um, People have also said it's helped with things like impulsive shopping or drinking, for example, or cutting back on smoking. I've had a handful of people come in and tell me it's very energizing, which is a little unusual because a common side effect is fatigue. But I've had some people tell me this medication has given them energy they've never had before. Um, I'm trying to think. It's a good question. I'm sure there's a lot more than I'm thinking
So
about right now.
I
Do
don't
you have
know
any?
if you can, I don't know if you can make this independent of weight loss, but there is overall MACE benefit, which is a fancy
Yeah,
way of saying cardiac event, heart attack, stroke,
that's true.
cardiac death, and all those things, you will decrease the risk of them if you're taking a GLP-1. The data behind it isn't that strong of being independent of weight loss, but along with the weight loss, we expect to see less cardiac problems, lower weight, lower cholesterol, lower inflammation in the heart. And these things all run together. You're improving your metabolic syndrome, so you're reducing your glucose, your blood pressure, your bad cholesterol, your overall weight.
Yeah, it's a good point. I mean, Ozempic and Wegovy are both FDA approved. They have that FDA indication for cardiovascular risk reduction, and I wouldn't be. And there's improvement in heart failure symptoms that have been shown through studies too. Like we're seeing improvement of sleep apnea. These medications will eventually be approved to treat fatty liver. They're going through clinical trials right now for a lot of different things. I think. We're going to see more and more good things. And I wouldn't be surprised at some point in our lifetime if these medications become standard of care for somebody who's had a heart attack or stroke. Like you leave the hospital with your statin, aspirin, and one of these medications. I might be getting ahead of myself. That is absolutely my own opinion. That is not based on
But in
anything yet.
clinical practice, it is what I've seen in the hospital. A
Yeah.
patient gets a heart attack. If there's any concern at all for diabetes, they are either starting the patient on a GLP-1, usually Victoza is what we use in the hospitals,
Okay.
or an SGLT2,
Yeah.
which also have some weight loss benefits, but also primarily a cardiac protective, like
Absolutely.
Farxiga.
Totally.
Um, I don't know how to answer this one, but maybe you can lead us here. Tirzepatide mixed with L-carnitine, is it better or worse?
Um, I don't know if that is like a compounded version that's mixed with L-carnitine or if it's being taken as a supplement on the side.
Well,
I
I know
don't,
it's a common supplement, but I've never seen
yeah,
it used together.
I haven't either. I don't know. I don't know if there's any data on it. It's not something I've seen.
Sorry, Lisa. Um, I believe this is the last question, and I'll take it. So yes, Jack, I will be practicing on Route 35 in right around the corner in Deal. I'm going to be joining Atlantic Health, and I'll be accepting new patients, but I believe I can't take any appointments being made before June. But thank you, Jack. I think that's all for questions, but it's really been a pleasure. Very
Likewise.
informative conversation. And if anybody else has any questions, this is your last chance.
Well, thank you so much. It's been such a pleasure being with you tonight. Good luck on your next steps
Thank
in
you.
your career. And it was wonderful chatting with you all tonight.
Thank you so much. It's really been a pleasure, and I hope we cross paths again.
Likewise. Thank you, everybody.
Thank you.
Take care.
Bye.
Bye.